You probably think that you're preventing cancer when you do tests like mammograms or colonoscopies, but you may actually be increasing your risk of harm. Most people think cancer screening saves lives by catching it early, but here's the shocking truth. Many of these tests, like pap smears, mammograms, colonoscopies, prostate screenings, aren't what you've been told. I'm Steph, founder of the Built to Heal Virtual Clinic, and after thousands of consultations with people, I've seen how the promise of early detection for cancer often creates more harm than health. In this video, I'll expose the dark underbelly of screenings and give you the information that your doctor probably never will. Pap smears. I'm sure you've seen the marketing campaigns. Get your pap smear. Cervical screening saves lives. How about mammograms? We are told that early detection saves your life. Get your mammogram today. And of course, we all know that this pink ribbon represents bravery and courage. And what about colonoscopies for colon cancer? This poster continues to repeat the same old soundbite that screening saves lives. Get your colon screened today and talk with your doctor. Then, PSA screen tests for prostate cancer in the men. Yet again, wouldn't you know it, we see the slogan that early detection saves lives. Do these tests actually save your life? Do they really extend overall survival? Let's take a look. Cancer screening will do two main things. First, it will diagnose more cancer. That's an obvious one. But the dark side of this is it will misdiagnose many cancers. It'll put people into treatment early who never needed it. It's been shown in the research on these screening tests that it creates overdiagnosis and overtreatment. This is well documented in the literature. More diagnoses means more patients means more treatments. And it turns out that many of those treatments were unnecessary according to the research that looked into this. And by the way, cancer drugs are the single most profitable drugs on the earth. Yes, that's correct. They're more profitable than even vaccines. While the argument for these screening procedures is that they catch things early and then they can improve your survival because they do so, the evidence we have suggests that screening tests actually don't improve survival in most cases. Dr. Barnett Kramer, Director of Cancer Prevention at the National Cancer Institute, has extensively studied cancer screening. The National Cancer Institute is the largest organization within the National Institutes of Health. In his paper, Cancer Screening in Theory and in Practice, he states that early detection of an apparently localized cancer does not in it of itself provide benefit. This means that finding a disease early doesn't just mean you improve your mortality or survival rates. And in fact, it can actually reduce survival in many cases.
As we have put more and more focus on discovering smaller and smaller lesions, some of which aren't even cancer at all, but so-called pre-cancer, we have led to over-diagnosis in some cases and over-treatment.
I want to highlight that this doc is not on the fringe. He is the Director of Cancer Prevention at the National Cancer Institute. If he is saying this publicly, repeatedly, something's really going on with these tests. You can see here that over the past several decades, as screening tests have increased, the deaths from these so-called cancers has stayed mostly the same. There are more diagnoses of the cancers, yes, but not a reduction in overall death. That's a pretty clear indication of overdiagnosis without any benefit. The second thing screening will do is artificially inflate survival time without actually doing so. Screenings have not been shown to reduce overall mortality, like I've said, overall death. This means that all screening does, usually, is diagnose people earlier in time, and they live the same amount of time they would have if they never got screened. You may be thinking, well, isn't catching it early good? As I said, it's been repeatedly shown in these tests, even though they diagnose more cancers earlier, the overall survival doesn't improve for people over time. In the research, this is called lead time bias. If you diagnose people earlier, then you can claim that they survived for more years, when in fact, all that happened is a label was given sooner in time. Their overall survival actually didn't change, but it artificially looked like it did. I'll put this up on screen and I want to walk you through this so you can really see a good visual of this. So here you see two people. Both people have the exact same cancer, and both people have the exact start of the cancer, okay? And they have the same biological onset of this so-called disease. And so one on the top there gets screened very, very early in time, and then they get labeled and diagnosed with an early stage of that disease. Now, the other person decided, screening's not for me. I don't want to get screened, too much of a hassle, whatever. And they just don't get screened. But what happens is both people end up eventually getting symptoms from their growing tumor, let's say. And so both of them will have the same symptoms at the same time. And the person who did not get screened on the bottom, they show up to their doctor saying, hey, I have this pain in my breast, and they end up getting diagnosed. Now you'll see on the top, there's what's called a perceived survival time that's much longer because it has a lead time only because the label was applied earlier. However, we've seen again and again with these screening tests, the death of both of these people, it has not changed. They still are dying from many different causes at the same time. So all that happened is that those who get screened earlier is having a lead time that's longer, which artificially makes it look like they survived longer, which in fact they didn't, because the time of death is not different in either of those cases. Let's talk about 4 main screening tests. First, cervical screening or the pap smear. Despite its widespread use, and I have used these tests as well, no randomized clinical trials have been done to show that cervical screening with pap smears significantly reduces death. Usually yearly cervical screening is recommended for women. However, as noted in Dr. Kramer's review paper, quote, there is very little data to support that this is effective. He says that although early detection might make it look like patients live longer, this is only because the diagnosis is simply made earlier in time, not because they lived longer. A 2023 meta-analysis of randomized trials found the following, quote, for cervical cancer screening, no randomized clinical trials with cancer-specific or all-cause mortality endpoints and long-term follow-ups were identified. Thus, we were not able to include cervical cancer screening in the present study. Cervical screening does not appear to reduce overall death or save lives on some grand scale. Let's now talk about mammograms. When it comes to the mammogram, no screening test has ever been more studied. We've been told that they save lives and every woman past 45 or 50 should definitely get one. In the past 50 years, more than 600,000 women have participated in 10 randomized trials. However, as one researcher said, given this extraordinary research effort, it's ironic that screening mammography continues to be one of the most contentious issues within the medical community. Why is this so? A fundamental reason is that it has been sold to women as a responsible thing to do by getting screened. However, these trials aren't so clear when you start to dig into them. So much debate goes on regarding them even today. Even most favorable tweaking of these statistics in the reviews and in the randomized trials, they admit that the reduction in cancer mortality when using mammography, if any, would be small, and they never show a reduction in overall death. A Cochrane review looked at 8 of these eligible trials using mammograms, which included 600,000 women from 39 to 74 years old. So it ran a pretty large gamut, and they found that breast cancer mortality was an unreliable outcome that was biased in favor of screening, mainly because a differential misclassification and cause of death. The trials with adequate randomization did not find an effect of screening on total cancer mortality, including breast cancer, after 10 years, and it didn't improve all-cause mortality after 13 years. Furthermore, a paper in the New England Journal of Medicine found that despite substantial increases in the number of cases of early stage breast cancer. So they caught the breast cancer earlier and earlier. They found that screening mammography has only marginally reduced the rate at which women present with advanced cancer later on. Although it's not certain which women have been affected, they said, the imbalance suggests that there is substantial overdiagnosis, which means overtreatment, accounting for nearly a third of all newly diagnosed breast cancers. And that screening, get this, is having at best a small effect on the rate of death from breast cancer. That's what they said. In other words, even if screening is helpful, even if they looked at it and tweaked it in the best of circumstances with the best statistics and pushing it towards having the most positive outcome, statistically speaking, the effects on an improving survival are very small, even in that case.
Yes, there is some would view it as a disturbing trend of increasing mastectomies and even increasing double mastectomies because of lesions, some of which are slow growing. And because of the terminology and because of the fear that women have, legitimate fear that something that has been diagnosed that may someday go on to cancer, there is an increasing tendency not only to have the lesion removed or have the lesion removed plus radiation and medical therapy, but to go all the way to mastectomy on that side or even double mastectomy. And I think we are learning that in many cases that can represent overtreatment.
How about radiation with mammograms? Women are becoming more and more worried about that. You can see here that mammograms are not a small dose amount of radiation, like many doctors may be telling you. They are more than an x-ray, and some much more, especially if you are getting them yearly. Radiation exposure from all sources can add up over one's lifetime. This is well known. So imaging tests that use large doses of radiation should only be done if there's good reason to do so. And I'm not so sure mammograms are one of them, just based on the conventional research. But you must decide for yourself. Now, if you feel you must get some type of testing and you don't feel comfortable getting mammograms, thermography may be a choice, which is just a heat measurement of your breast tissue. That might be an alternative if someone really wants to have some diagnostic tests done. However, my assertion here is that trying to catch cancer early is probably not the right approach, even when you go and look at all these studies and start to find out that that whole paradigm doesn't seem to pan out the way that we originally thought. Let's talk about colonoscopies. A colonoscopy is actually a screening test, but it's also a treatment. Many people don't know this. They use a camera to look for polyps in your colon, and then they cut them out on the spot in the large intestine and rectum. Current guidelines recommend screening colonoscopy every 10 years in average risk individuals. Contrary to what the poster at your doctor's office will say, screening benefits are not so clear. The marketing posters, like this one, will tell you that you have a 90% survival rate if you find the colon cancer early. They failed to give you the full story, and this is what you call lying with statistics. We have been using these tests for decades, even though at the time, quote, no study has clearly demonstrated benefit, as this older 2005 review says. But more recently, there were some randomized trials, and they looked to assess colon cancer screenings. There was a large randomized controlled trial designed and sponsored by the National Cancer Institute, and it was called the Prostate, Lung, Colorectal, and Ovarian Cancer Screening Trial. That's a mouthful. In that trial, what you'll see is that prostate screening has no evidence of benefit. That's what they found. Lung screening for lung cancer didn't save lives. Ovarian screening with ultrasounds and pelvic exams didn't decrease death. However, for colon, we see that this trial found that screening with flexible sigmoidoscopy was associated with a significant decrease in colorectal cancer incidence. This means that screening appeared to modestly reduce mortality from colorectal cancer. But let's look a little deeper, as there's more to the story when you look at that study. In a recent 2022 randomized trial, they had people assigned to screening colonoscopy and those assigned to no screening. There was a 10+ year follow-up period. You can see here that there was a modest reduction in risk of dying from colorectal cancer when you were screened versus if you were not. However, strangely, the all-cause mortality, meaning death from any cause, was the same. This means that even if the colon screening reduced death of some people from the apparent colon cancer diagnosis, they didn't actually live longer overall. They still died at the same rate as other people for other reasons. So this leaves the question if the treatment itself may have worsened their outcomes or if other factors worsened their outcomes. Either way, it did not extend overall survival. This finding is similar in other studies and other screening tests of the colon. A randomized trial with a 21-year follow-up found the same thing with screenings. Quote, a reduction in all-cause mortality was not evident in the invited to screen group compared to the control group overall. Again, this points to the fact that they can show you in some form or fashion that screening can help reduce or treat polyps, treat tumors, but if it doesn't extend someone's life overall, what would be the purpose? All that seems clear is that screening the colon and rectum may have some benefit, but it doesn't appear to extend life, and truly that's all that really matters. Next, let's talk about prostate screening, PSA. Following widespread use of PSA screening tests in the 80s, the incidence of prostate cancer rose dramatically in the US. No surprise there, right? You do more screenings, you're going to get more diagnoses. More screening tests means more found cancer and more diagnosis of prostate cancer. But it begs the question, as always, has it saved all these lives that we think that it does? The issue is if we treat men unnecessarily when it comes to getting a wrong diagnosis, there are really big consequences. Treatment of this has side effects like incontinence, impotence, meaning you can't hold your urine and you can't hold your erection. And ask any man if that's a cost that he would want to pay if it won't help his outcome and it won't actually help him live longer.
Prostate-specific antigen is a blood test that has been used for almost 2 decades for the early detection of prostate cancer. The problem is that it is not specific for prostate cancer. It just is specific for almost any lesion or any abnormality in the prostate gland, including simple benign growth. And that, in part, is why the United States Preventive Services Task Force, which is an authoritative methodologic panel that makes recommendations regarding prostate cancer screening, attached a grade D to the evidence. That is, they recommended against the routine use of PSA screening to detect prostate cancer.
According to the research, PSA is anything but specific. For example, non-cancerous prostate tumors, so-called infections, and even some over-the-counter painkillers can raise men's PSA levels. On these grounds alone, PSA clearly has some serious problems. The U.S. Preventive Services Task Force now no longer recommends routine screening for prostate cancer. And for men over 70, they actually recommend against screening, as they say the benefits do not outweigh the harms, like the incontinence, the impotence, the pain from surgery and radiation, and all the downstream effects. Now, the discoverer of PSA, Dr. Richard Ablin, actually wrote a groundbreaking book called The Great Prostate Hoax. Yes, that's right. The scientist who discovered PSA calls it a hoax. He said that, quote, I never dreamed that my discovery 4 decades ago would lead to such a profit-driven public health disaster. The medical community must confront reality and stop the inappropriate use of PSA screening. Doing so would save billions of dollars and rescue millions of men from unnecessary debilitating treatments. He goes on to say that the test is hardly more effective than a coin toss. As I've been trying to make clear for many years now, he says PSA testing can't detect prostate cancer. And more importantly, it can't distinguish between 2 types of prostate cancer. He says the one that'll kill you and the one that won't. The results from all relevant trials were systematically reviewed. They found that there was no evidence of improving death from prostate cancer by using PSA screening. So, where does this leave us? Selling these screening tests has become quite easy. Everyone now believes, because we've been told to believe that the earlier you test, the better your outcomes, and people line up for their yearly screening tests. Anywhere you look, you'll be nudged by marketing campaigns, by your doctors, by your friends and family that you better get screened for X cancer or Y cancer, such as this campaign. I learned the hard way. Schedule your appointments. How about the slogan that came from an old American Cancer Society poster? They said, if you are a woman over 35, be sure to schedule your mammogram unless you're still not convinced of its importance, in which case you may need more than your breast examined. So calling you stupid. People think if only we spent more money on cancer research, we would find the cure. Let's put more money into research. Or we could develop better tests that would lead us to better outcomes. However, in 2024, the government has spent nearly $50 billion, given it to the National Cancer Institute, and look where we are with that. And every year, it's the same billions and billions of dollars we funnel into research, and where has it led us? In conclusion, as Dr. Kramer and many other scientists and the research summarizes, the perceived benefits of these screening tests that I've discussed don't appear to lead to vast improvements in survival rates. Most of them don't improve survival rates even slightly at all. In fact, it can be said that none of them improve overall survival rates. If many of these screenings don't lead to longer lives or better lives, what are we doing? Even if they claim one test can reduce a diagnosis, but if they can't show that it reduces overall death, then there's not much to get really excited about. Reducing all-cause mortality, improving overall survival is the marker of improving overall health, and that's what we're after. This is what we would want to see. We can get in the weeds with models, more diagnoses, and finding growths early and cutting them out, but none of it matters if people don't live longer, healthier lives. Yet most of the information you see on these tests will continue to lie with incomplete statistics, partial stats, because cancer screening and early detection is a large marketing funnel, I'm sorry to say. It's crucial for people to make informed decisions, not be scared into many of these procedures or treatments without really understanding what's going on. Catching things earlier is not necessarily better, it turns out. Sometimes early is just wrong.